Thank you so much, Dr. Rohan and Dr. Pooja, for inviting me here. Thank you, IRSI, for the opportunity. So I'll quickly start my topic. And as rightly said by the previous speakers, the post-refractive surgery patients are gonna pool in your OPD very soon. Nowadays, we are seeing the post-RK patients. But very soon, your huge chunk of the patients for cataract surgery will be the post-corneal refractive surgery, the post-LASIK patients, the post-SMILE patients very soon. So obviously, these patients are super patients because they have been living without glasses after the corneal refractive surgery, and they would certainly like to continue to have the life without glasses. So the scope of my presentation would be how to calculate the IOL power with the available resources, and also when these resources are not available. Because this is very important, as Dr. Rohan told me that there will be many of the youngsters who will be joining in, and not all the resources might be available to them. So how to go about in those particular case? Not only that, once we choose an IOL power, what is the specific type of IOL I should go for? And at the end, you have done enough for the patient, but you have to have a peaceful sleep. Just for the postgraduates, we know that the post-LASIK eye or the post-myopic PRK, what are the changes? There is a change in the anterior to posterior corneal curvature ratio, and there's a lot of change in the refractive index. We know that the peripheral cornea comes in the center due to the flattening. What happens in an hyperopic is a central bulge or the central steepening. The rest all factors remain the same. What happens in a post-RK is the anterior as well as posterior flattening happens. And similarly, the more peripheral cornea comes into the center, and there is a change in the refractive index. Now, this is very important. What happens to the spherical aberration after the myopic laser correction? As we all know, spherical aberration is the peripheral rays converging more than the central rays, causing a spherical aberration. The 0.26 is obviously for the Western population. It's measured at around 6 to 8 millimeters of the pupillary size at the corneal zone. What we have here in India is a mesopic pupillary size of around 4.2, and the average spherical aberration is around 0.16. 0.1 to 0.16. What happens in the myopic LASIK? We are flattening the cornea. So as you are flattening the cornea, so we see that there is a lot of increase in the spherical aberration. The spherical aberration, which was 0.26 earlier, might be jumping to a 0.42 depending on the magnitude of the ablation that we have done. What happens in a hyperopic LASIK? Here you are steepening the cornea more. Once you're steepening the cornea more, the central rays are going to converge more as compared to the peripheral rays. And the spherical aberration actually reverses in them. So your spherical aberration is going to jump onto the other side. So it's very important here to understand that the hyperopic LASIK surgery done will have a spherical aberration on the other side, and perhaps would benefit from an aberration neutral lens or a regular spherical lens. The same happens in a myopic radial keratotomy. There is increase in the spherical aberration. When coming to the IOL power calculation, we all know that the assumption that the posterior radius of curvature is steeper than the anterior radius of curvature by 1.2 mm is no longer valid in refractive surgery, and that perhaps is a cause that we get an overestimation in the corneal refractive power. We know that the peripheral cornea comes more in the center, and that's why the regular keratometry, which works well in a virgin corneas, might not work in this. There's a lot of change in the corneal refractive index. The Myers are located further away from this corneal center. In a surgically flattened cornea, the central cornea is not measured. So these are all the errors that happens in post-LASIK, post-corneal refractive surgery patient. Now, also, we have to understand that the third generation formulae, they used to calculate the effective lens position, as we have already know that the effective lens position is one of the major factors in an IOL power calculation. The third generation formulae used to estimate it or predict it using the axial length and the K values. Using that, it used to give an IOL power. Now, this all will be false because the K value, the post-LASIK, if the flattening is there, for example, if the K value is 36, 37, These formulae will assume that the chamber depth is less and there will be an underestimation of IOL power because there will be an underestimation of the effective lens position. And similarly, we are going to end up in an hyperopic surprise post-operatively. That's in a patient who has undergone a myopic laser vision correction, and this will be on the other side if you are treating an hyperopic laser vision. Now, coming to this particular point, when I have a patient sitting in front of me in my OPD, first thing that I ask myself, do I have access to the topography? Do I have access to the optical biometer or any other biometer, be it LensStar or be it IOL Master or is the IOL Master 700? Do I have access to one of these? Or what to do if I don't have access to any of this? I have my auto-K values on my auto refractometer and I have an immersion this thing. Now, can I just proceed without the topography and optical biometer as well? Well, these are my further slides are going to answer that hopefully. First and foremost, do I have an access to a topography? And suppose if you don't have access to a topography, the question that you ask yourself is should I refer this patient for a topography? And if yes, should I send him for a place where there is a Placido topography, or should I send him to a place where there is a Sheimflug or an OCT-based topography? What is the role of the topography? The first and foremost role of the topography is to determine ablation pattern. Is it a myopic laser vision correction done, or is it an hyperopic laser vision correction done? Obviously, in some of the patients where the K value is 34, 35, you will certainly make sure that you assume that it's a myopic laser vision correction. But in hyperopic, where the K values are around 44, 45, you will still be in a little doubt because if the pre-existing K values are around 47 or so, you will be in a doubt because these patients might not know the refractive error they have undergone in the laser correction, and they will just come to you that pehle laser hua tha, and uske baad they don't have much of a details. At the same time, we are supposed to see is the ablation pattern. So the images that you can see on your right and left are the fairly centered ablation pattern. So these are not decentered ablation. These are the patients who will do really well even if you plan for a premium IOL, for example, the toric or the multifocal lenses for these patients. Another role for a topography, particularly if I'm planning a toric IOL, is to ascertain that the toricity is regular or an irregular. The outcomes will be much better if it's a regular astigmatism as compared to something like an irregular astigmatism or a decentered ablation. Now, all these answers can be given by a Placido itself. So for us, very frankly, a Placido is there to identify the type of laser correction, to check whether the ablation is center or not, and to identify a regular astigmatism or from an irregular astigmatism where the toric IOLs will give a better outcome. While a Sheimflug based, if I have a Sheimflug and an OCT based, it can give me the anterior as well as the posterior curvature as well. For example, if I have a pentacam, it gives me an holiday EKR map, which shows the zonal equivalent K readings to me. At the same time, it shows us that how evenly the keratometry values are being distributed over the cornea post LASIK, similar to what we are getting in a Placido base, whether it's an regular astigmatism or an irregular astigmatism. So Sheimflug is mainly to know the equivalent refractive power or the true net power, and then all the other things that are done by the Placido topography as well. So this is very important that the Sheimflug imaging actually gives you the refractive power of considering the refractive index as well. This has been covered by the previous speakers, and I'm sure if you have the optical biometer, if you have the IOL Master 700, the Barrett suit, the Haggis L, they do really well. And I think most of the optical biometers now have the true K. They take care of the anterior curvature as well as the posterior curvature as well. They are based on OCT, and they also have a topography incorporated. Most of these optical biometers will give you a fairly accurate results for calculation of the IOL power formulae in these patients. Now, first that you had a topography, which you are planning for a patient who are having post LASIK, hyperopic or myopic LASIK. Second, you thought that you have an optical biometer as well. Now, despite these two, this is something that we should do, is that use this freely available software on ASCRS. I'm sure everybody would be using that. Everybody must be using that by now, but a little bit I will add in that in this particular talk. Now, we are very familiar with the screen. Now, what I always tell everyone is, do make sure that you enter a target refraction of not 0. Particularly in these patients who have undergone a myopic laser vision correction, and keep a target refraction of around minus 0.75 or minus 1 always. The pre-LASIK data is not used anymore, and so is the post-LASIK refraction, which has to be entered before the development of cataract. This is by and large, we have never got this particular data. Then comes the topography. Now you have an access to a topography. For example, if you have an Atlas or the Galilee Pentacam, you can take those values from there and put it here. And this one, for example, if you have a Pentacam, just go to a Pentacam EKR map and you're going to get this apex 4 mm zone, what is then equivalent K reading, and then you're going to have a pretty fairly accurate calculation. Suppose if we don't have a topography in a peripheral center, you can't refer the patient. The patient is just because he has to undergo cataract surgery and you don't have any resources. Whatever K values you have, you can enter those K values here from any device, enter the axial length, the anterior chamber depth, the A constant, and the ASCRS calculator is going to give you the formula IOL power using the Sharma's no history method, and which is fairly accurate. So this is how at the end you get the IOL power, and the average of the IOL power or the higher IOL power you can select so that the patient lands up into a little bit of myopia. I'll just give you one small example. The patient LASIK done many years back, now having this kind of topography fairly centered. If you see the right eye, we see the left eye. And this Placido tells me basically one thing, that the ablation here is done is fairly center, and it is not a decentered ablation. So I can perhaps go for a premium IOL in this patient. Was having some amount of toricity seen in the patient in the left eye to around 1.7 diopter. So the left eye was planned for toric IOL, and you can see this patient, and the IOL power was calculated. We had used the IOL calculator, the ASCRS one for the right eye, and this is what we got, the IOL power just by entering the K values from the optical biometer itself. We used the Alcon Toric calculator for the left eye, and most of the times you're going to end up with fairly accurate results. Occasionally you'll get in very extreme outcomes of more than 2 diopters from what you have targeted, but by and large you'll have a patient who is going to have a fairly good accuracy by using this ASCRS software. Now, what if I don't have access? As I already told you, just enter the auto K values or any keratometer values in that ASCRS calculator, put the axial length. Axial length, as I earlier also told, these are designed for the optical biometers. Just add a 0.15 or 0.2 to the immersion axial length and put that axial length here. ACD and IOL constant, just put it on the IOL power, and you're going to get a fairly decent IOL power calculation done by using a Sharma's no history method. It's been proven beyond doubt that this gives a wonderful, wonderful, wonderful outcome. Now, once you are done with calculating the IOL power, that for if a patient, I am going to go for a 18 diopter lens, and the question comes as spherical or aspheric lenses, toric or multifocal lens for that patient. Also, we have to do, so for example, if you have an access to topography that gives you the spherical aberration, if the spherical aberration is on the positive side, it happens in the patients who have undergone a myopic laser vision correction, which has a central flattening. And the choice is obviously the one with a negative spherical IOL, and the opposite for an hyperopic laser vision correction, where you're going to go for a negative for an aberration neutral or a positive spherical aberration IOL. So this particular slide tells us about what IOL selection I should go for if I have a patient who has undergone a myopic LASIK as compared to someone who has undergone a hyperopic LASIK. Now, toric lenses, yes, you have to understand that the type and magnitude. If you are planning a toric lens in a patient with a post-LASIK, a topography is a must without any other doubt. You have to have a toric lens. Outcomes are more compromised in RK patients who are having a larger cuts and a smaller optical zone. But if you have a fewer cuts in case of RK and the optical zone is fairly large, then perhaps you can still go ahead with the toric lenses in this. And then this slide I've already shown that you have to identify the type of astigmatism that are dealing with the regular and irregular astigmatism. Multifocal, it has a limited role, but considering the newer laser platforms which induces lesser aberrations on the cornea, multifocal still come handy in patients who are having a fairly good centered ablation. The pupillary size, the mesopic pupillary size are not really large. The mesopic pupillary size are not coinciding with the smaller optical zones. Well, multifocal in these patients should be very judicious. The most important thing that I always do if I'm doing a multifocal in them is I always underpromise. I tell them the lasered corneas or the RK. I've never done a multifocal till now, but yeah, if you have a lasered corneas, you have to make sure that you highly underpromise to the patient. So take home message for the IOL power calculation: Placido for checking the ablation, Sheimflug for calculation, IOL Master or Lensstar for incorporated IOL power calculation. If you don't have above, just use the K values and the axial lengths in the online calculator. Coming to in selection, IOL selection is an important and as important as an IOL power calculation post corneal refractive surgery. If we are planning a toric, please get a topo done. Placido for checking the ablation and Sheimflug for calculation, and always under promise. And also aspheric IOLs for myopic ablation, post myopic LASIK ablation, and spherical IOL or the aberration neutral for an hyperopic LASIK patient. Thank you so much. I kind of finished quick in 12 minutes. Thank you so much.
Thanks, Mukesh. That was absolutely lovely presentation, giving a very important insight for post LASIK. We are going to have a lot more patients with post LASIK cataracts coming to us, and there's an exodus. Every week you get a few of them, no question. One of the formulae which I saw was Haigis L, myopic, which you showed in one of your slides. So before the Barrett's came up and the True TK came up, Haigis was fairly comfortable to work with. It has a LASIK operated eye. IOL Master comes out with a very good formula. So you have to be careful whom you are trusting, which machine you are trusting. But as you said rightly, that under-promise these patients. But one of the problems with these patients is it's a calculation is difficult for you. You have multiple machines telling you multiple things. Your topography gives you some other reading. Your K reading gives from an autocheronometer gives you something else. Your varion gives you something else. Each machine has a mind of their own. And you are confused what you're going to give to the patient. And each one of them would mark you one thing with these patients. 15, 20 years, they have undergone spectacle-free freedom. So they are not going to like the idea that you're going to tell them that you might need to use glasses. That's one point which is important. But as you said so rightly, given the new formulas which are available, you hardly can really go wrong. And the ASCRS website, which is updated so well, it's free for everybody, and it should be made use of in almost every patient. Partha, your opinion?
Yes, sir. Very nice talk, Mukesh, and covered everything for our youngsters. Maybe one practical aspect that I would really want to reinstate, and this has been my experience, and I'm sure that there are other people with similar experience, that before we had all the formulas, we burnt our fingers with the post-refractive surprises, the post-cataract surprises for these refractive patients. So quite early, what I started doing is, after extracting the cataractus lens, I got my best optometrist to do an on-table retinoscopy. And that gave a very accurate value. And the accuracy of the value, we knew it would not be spot on, and we made it a little on the myopic side. So if he got a retinoscopy reflex of 10, doubling it and making it a little on the myopic side, after that, till date, it's nearly about 10 years now, I've not had a refractive surprise. And now with the newer formulas, I still carry on with this. And whenever there's a discrepancy of the formula to my optometrist's value, I still am on the side of my optometrist. And God willing, we have really proved that in quite a few cases, even the best of formulas that we are using now can land up with some amount of surprise. Yes, not a very big deal, but some amount of surprise. So, I still value this optometric, the retinoscopy reflex. And after placing in the lens, the optometrist checks once again whether it has been more or less neutralized. And this becomes all the more important even with the RKs, where it is haywire. I mean, there's a huge cylinder, there is a poor reflex, but if it's a good optometrist, he'll be able to tell you, yes, the surprise is not there.
Ramu, then how much do you fill up, Partha? Do you fill up with viscoelastic? Do you fill up with saline when you go in for your refraction by the opto?
Yes. So initially, of course, the viscoelastic methyl cellulose without any bubbles and optimally fill, not too hard, not too pressed. And after removing it, then it is the BSS, which is filled, and then that final retinoscopy is done to ascertain that there is no apparent surprise.
So great, Mukesh. Thanks for sharing your insight. And of course, Partha, as usual, smiling all the way through. Thanks for being there and giving your valuable comments.
So shall we ask these youngsters a question, sir?
Yes, please.
So say, Anshika, if you were to start a practice on your own, okay, yes, let alone Dehradun, okay, on your own in, say, Baroda, what would be your take of going in for the machine, the biometer, the phaco machine, and the microscope? Where would you invest most?
So as we discussed today about biometers, so optical biometry is something that one would definitely want in their setup in the long run. But maybe when you're starting, depends upon your budget, what to go for. Something to really invest in, which I have gathered, would be a good microscope, because that is something you're going to be using universally on all your surgeries, and then eventually an optical biometer is a must. And phaco, I feel that if you begin with something basic, but then slowly move forward, so that is a good move. But I think a microscope would be the thing that I would invest in first and most importantly.
Partha, should I put in a word on their behalf?
Yes.
I have to just reverse the clock. As I say, the residents needed the best machine, actually speaking. When they were practicing, they needed the best microscope.
Yeah.
The experienced surgeon, as Ramu said, doesn't matter whichever phaco machine, he'll handle it beautifully. Whichever microscope, he will handle it beautifully. The best, first, everybody should be very clear that whatever money you put in equipment, in your cataract equipment, you will make it within no time. So buy the best. Borrow money. Banks are willing to pay you. Money is freely available now. We used to pay 12 and 14, 16% interest once upon a time. Now it's 6 to 7% interest that you're getting in. Buy the best. Like you gave a good example, IOL 500, IOL Master 500 at 13 lakh, a refurbished, fantastic, rather than going for a scan. So use your thing judiciously, but don't economize on a bad instrument. Your confidence will suffer if your microscope, you don't see what you're seeing. And if your phaco machine is not working very well, it's not one of the best ones. Your confidence in the beginning is the most important, and the best result that you give in the beginning is what is going to take you for the rest of your life. Don't compromise. Whatever money you put in, you will make it within no time. So it's a mental block. Learn to borrow. Learn to borrow money from the banks or whichever place that you can get. You will be able to pay the interest and the original and buy newer equipments within no time. This is a clear message I would like to give the younger. Don't start that, no, in the beginning, I would buy a smaller machine, I would buy this.
I agree. As Dr. Partha said and Dr. Mehta said, that in my second year of practice, I bought a pre-owned IOL Master 500. It's still working well, and it really helped to pick up the practice. And perhaps all those premium lenses I can confidently more offer to the patients. if I have the IOL master with me. So yes, invest early and get it early.
Yeah, and one myth about these pre-owned machines, we as Indians, we hate to take in something that has been used, and we think it's a showdown on us. But believe me, actually, if you go into the logistics of these pre-owned machines, most of them are from US, where the institution, after 3 years, does not take in that machine. So it goes back to the company. They refurbish it and send it to all over the world. And India, it's not only India, it goes all over the world. And they have a warranty period as well. So they are not bad, they are not substandard. And if they are giving good results, it can go on for a very long time.
True. True, absolutely. So don't buy your first car a BMW. You don't have to buy a BMW. Buy an Alto. That's a depreciating equipment. But if you're buying your microscope and or your phaco machine, put your money in that.
Absolutely. So because I remember reading an article very recently about 66% of closed cases of CPA in England were actually because of faulty biometry. So it was not what you did in the surgery per se, but it was because of what happened in the biometry part of it that the doctors actually had to pay the patient. Biometer, most definitely, invest in it, because as you said that nowadays with a lot of am I audible?
Right.
Yeah.
Oh, you're audible.
I'm saying that nowadays, anyways, because of all of us getting trained at bulk centers where we get a lot of surgeries. So we're used to using the different phaco machines. So even a basic phaco machine, we're all right doing surgery with. But the biometry part will never be able to, take care of it because it's not equal. I agree that all phaco machines are not equal, but since you got trained with so many cases already, you can handle it. But when it comes to biometry, it has to be accurate.